We're going to talk today about Chapter 6, Assessing Mental Status and Substance Abuse. Chapter 6 objectives include discussing concepts of mental health and mental disorders, discussing the risk factors for mental health disorders and substance abuse, describing an accurate mental health, risk for substance abuse history and assessment, using the Glasgow-Coma scale for high risk for rapid deterioration, describing the warning signs to assess for Alzheimer's disease, and correctly using the questions for assessing suicide risk. You will differentiate normal and abnormal findings of mental health status and substance abuse assessments, and differentiate between Alzheimer's, dementia, and delirium. Finally, you will be able to describe the confusion assessment instrument that is used to assess patients for delirium. So mental status is the client's level of cognitive and emotional functioning. This is an essential part of someone's total health. Health is physical, mental, social well-being. That is the holistic patient. So a healthy mental status is someone who can think clearly and respond for optimal function. We observe these behaviors, we ask the patient the questions, and they respond. So this is very much a self-report. The definition of a mental disorder is a behavioral or psychological syndrome or pattern that occurs in individuals. It reflects underlying pathology with some clinically significant consequences. So some examples of some mental health disorders maybe you're familiar with: PTSD, post-traumatic stress disorder, depression, panic disorder, social anxiety, various anxiety disorders. So some of these may be familiar terminology to you. So some of the factors affecting mental health can be economic and social factors, maybe some unhealthy lifestyle choices, including substances, any history of exposure to violence, personality, spiritual, cultural, that exposure in their environment and family. Any changes or impairments in the neurosystem can present as some mental disorders. So we have to use our assessment skills to find out what's going on with our patients so we know how to help them. The psychosocial development level and issues can also be related to some development and that might manifest and look like some type of mental disorder. So it's important to be able to assess this completely. So we're going to look at dementia versus Alzheimer's in this chapter. And so dementia is a variety of symptoms with the loss of cognitive function. Some of the general symptoms are memory loss, problem-solving issues, difficulty completing tasks, confusion with time and place, trouble understanding visual images or relationships, decreased or poor judgment. Now, a lot of people may see that aging, they think, oh, well, the person's just older and that's where their problems lie. But when you start misplacing things or withdrawing socially, having sharp mood swings, those are more indicative of dementia than, say, a change in your small change in your memory, like recall or slower thinking. That is looking at dementia versus aging. So Weber and Kelly maps this out as Alzheimer's versus age-related changes as well. Alzheimer's, frequently these patients have very poor judgment. They're unable to manage a process, lose track of date or even the season, may have difficulty having a conversation because they're not able to think of the words. But age-related, and many of you might have had this occurred where you misplaced your keys, or maybe you missed a monthly payment for your water bill, and you just forgot. Or even lose things from time to time. Those are not indicative of a mental disorder. Sometimes those things just happen, but the severity and the frequency really do lead people to identify they may need to be assessed further. So, in the evidence-based dementia versus Alzheimer's, some of the risks are increasing age. Age doesn't mean absolutely they have to have this, but it is related. Some genetic and family history obviously plays a part. Some racial constructs may be frequently have issues with that, but of course, like any other um, race or culture, that doesn't automatically mean anything, right? We have to provide an assessment. Some of the modifiable risks for these mental disorders is hypertension. And we know that hypertension is related to vascular disease, and decreased vascular disease is poor perfusion to organs. And so we, um, uh, we know the brain is one of those organs. Any head trauma, we know that there are some concussions and head trauma that can lead to early onset mental disorders later on. Smoking as well, nicotine is a vasoconstrictor. Any history of depression or hormone replacement therapy can also impact vasculature. So some of the education we might provide for the patient is engage in mentally challenging activities, use that muscle, that brain, healthy behavior like weight, avoiding those substances we talked about, and exercise, working that vascular system. Anything that increases head trauma risk, you would want to think twice about or wear helmets when you're doing those things. In chapter 6, we talk about substance abuse. And this is something that, as healthcare professionals, we talk about substances, the opioid crisis. You've probably heard quite a bit about that. Substance abuse in adolescence and different kind of substances. And I think that it kind of rotates with what is the um, things that are currently going on. So you will need to assess and identify and talk to your patients about this. And this can be an uncomfortable conversation with your with your patients. But um, we need to know what somebody's taking so we can hopefully prevent some very uncomfortable issues with withdrawal and things like that. So obviously the goal is to reduce substance abuse and protect the health quality for your patient. And we can only help do the best that we can while they're in our care. But it takes us knowing honestly what's happening. And so we have to provide that trusting, honest, safe space for your patient, to be honest with you. So there are some simple tools that you can use, and one of them is CAGE. And we use this when we're very frequently talking about alcohol use and things like that. This CAGE self-assessment tool is, have you ever cut back on your use? Have you ever been annoyed or angered when somebody is questioning you? Have you ever felt guilt about your use? Have you ever had an eye opener to get started in the morning? And even if you're not asking somebody directly these questions, but they are giving these answers with their conversation, you might be concerned that this is something that maybe even more than what they are saying. So it's just a guide to help you to understand. But the CAGE self-assessment tool is for the patient. Um, so it is definitely a conversation, hopefully, that you will be able to view and practice um, as we try to provide the best care for our patient. When we're asking patients about mental health disorders, there is still quite a stigma when we ask about history and all those kind of things. So you want to be as objective and professional as possible when you're asking some of these questions and explaining why I need to ask these questions, why the purpose of these questions is so important, so we can provide a baseline of care for the patient. You're going to observe their verbal and nonverbal cues, and that might tell you some of if the responses are reliable. If your patient is not making any eye contact, is their posture and their whole body language is working against the situation, that can be difficult to get true and honest answers. So we need to give them the space, understand that these are sensitive issues, and a lot of times, especially as issues with sexuality and dying and suicide risk and substance abuse, it can be very, very difficult, but your demeanor and how you present this information is really going to affect this whole conversation. You want to note the questions and why I'm asking for these questions. And I would just continue to reassure your patient that I'm asking these questions so we can provide the best care for you. You absolutely need to have their baseline data, their present health concern. What is the most concerning thing right now? Any past treatment or hospitalizations for mental health issues. And I would also include any medications that they're taking, what they're taking the medications for, um, and how long they've been taking them as an important past health history. Their family history, lifestyle, and health practices, as we know, is very important in helping understand your patient. So when we're asking them these questions, depending on what comes with their health history, you may need to perform a full mental status exam if the screening suggests that this patient is in an anxiety, depressive, or cognitive impaired crisis. You may need to do a full-blown evaluation or refer for your physicians. Especially if the family is concerned about some inappropriate social interactions or situations that have come up, severe memory loss, things like that. I always listen to the family and let them try to um, uh, have their um, their information shared. But ultimately, it comes straight from the patient, and that's where you're going to get the best information. The most objective data comes from the questioning and the testing with the patient. So when we're providing a physical assessment, some of the mental status things we're going to identify is their level of consciousness. Are they alert? Are they oriented? You're observing their posture, their behavior, their affect, which is their mood, right? Um, their dress and grooming hygiene. When they're responding to your questions, their speech is obviously very important. Are they slow speech, repetitive, fast speech? Um, that their conversation will help give you the identify any thought processes and perceptions they have in the conversation. So their cognitive abilities, some of the details about these cognitive abilities of orientation, concentration, recent and remote memory, use of memory to learn new information or new learning, abstract and judgment. Um, the SLUMS test is something that maybe you've heard of that we use to evaluate some of these pieces, trying to identify patients who are at risk for Alzheimer's. So I break down all these pieces for you and how you're assessing these. We've talked about alert and orientation ×4, probably in your clinical sites and in Weber and Kelly. Your Glasgow Coma scale is a scale that we use frequently to identify this alertness as well. So you can see on the scale that the higher the score, the better things are. The lower the score, the 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 poorer the patient's doing. So a 7 or lower is considered a coma. So here's a description of the levels of consciousness, and a picture on the right may help you identify that visually. So lethargy, opens eyes, answers questions, falls back asleep, obtunded, stupor, coma. I don't know if I agree with this there on that picture, but the description does not respond to verbal stimuli, does not speak, decorticate or decerebrate, no response to pain. When we are doing our objective assessment, we talked about observing posture and gait. Here are the expected findings: that the patient's relaxed. If they're slumped posture, this might indicate some type of depression. We observe behavior and affect. Observing dress and grooming, hygiene. When you're looking at the tables in chapter 6, the abnormal findings are going to be very helpful. Our facial expressions, eye contact can be different for different cultures, so you want to take that into account. But if somebody is not making any eye contact at all, this might make you feel like maybe they're um, uh, feeling shamed and depressed. That can be possible. We talk about the facial expressions of Parkinson's and how that might look, that flat, mask-like face. So there's speech, moderate tone and pace, any slow, repetitive speech or fast, loud speech are abnormal findings. If somebody is having difficulty formulating words or remembering words, that may be indicative of some other neurologic issues or dysarthria. So moods and feelings and expressions. We're going to ask the patient, how are you feeling? And they should be able to express their feelings appropriate to the situation. Being in the hospital, a lot of times people will say, I feel terrible. And that may be expected, that they're not having a great day while they're in the hospital. Hopefully they can verbalize positive feelings, hopeful feelings. But if somebody has anxieties, fears, uh, or sadness, that doesn't necessarily mean that those are abnormal for this situation, right? But if they've had uh, are not hopeful or rage, um, or euphoric, this may not fit that situation. So we may need to evaluate further. So when we talk about inventorying these depressive symptoms, maybe some symptoms of depression that you didn't know about is the trouble sleeping, sleeping too much or not sleeping enough, maybe changes in appetite, changes in weight gain or loss, concentration, the thoughts of suicide and death, of course, but even sometimes feeling your energy and restlessness, and maybe you're not sure why this is feeling like this. And I would tell you right now, especially in this time that we have, that I've noticed a lot more um, uh, people, even in my life and in the healthcare setting, that have one or two or many of these little pieces. The anxiety levels are very high. And so we just need to recognize that and see that in ourselves and hopefully find ways that we're coping in a way that optimizes our own health. So we can help our patients optimize their health. But this is a self-report. So when we're talking to our patients about suicide risk, and you are going to ask your patients if they've ever felt that they had a past attempt at suicide, a plan, have any thoughts of worthlessness or anything like that, felt hopeless. These are important things that we address for our patients. So we need to normalize asking in this conversation and make sure your patient knows that this is a safe space for them to have these discussions. So there's a sad person suicide tool. Some of the risk factors: sex, age, depression, previous attempt, substance use can precipitate some of these thoughts. So lack of social support or frequent sickness. If patients have a chronic pain, chronic disease like cancer, arthritis, some of these things can really increase these instances. So we just need to have the conversations about it and allow the patient a safe space to share these thoughts so you can get them the resources that they need. So when you're observing thought processes, clarity, content, and perception is what we're looking for. We want the patient to have these free-flowing thoughts, following directions, expressing some realistic perceptions. Um, uh, we talk about if your patient has delusions or if they are hallucinating, things like that. We find more about their thought processes. So the listing of cognitive abilities, so orientation, how we're asking these questions, the person, place, time, and situation you are going to assess your patient for these. Their concentration and memory, can they stay focused and attentive? Do they get distracted easily? When you're talking about recent memory, you're asking about something that happened today at a specific time. Now, remote memory is asking about past events. What happened in 2001? So, cognitive abilities and new learning, you're asking a patient to say four unrelated words and then have them repeat the words later on. That is considered new learning. They don't have to be new words, but it is new learning. So, abstract reasoning is a client is comparing objects. Are an apple and an orange the same? So, judgment. What would you do if a police officer pulled you over? When you get in to start the car, what would you do? I'm going to put my seatbelt on. Those are judgment questions. Some other cognitive abilities are visual perceptions. And on the slums exam, you'll see where we ask the patient to draw a circle and then we ask them to draw a clock. And they want you to draw spatial numbers for 1 through 12, and then we'll draw the big hand and the little hand for a time. So a dimension assessment tool includes these pieces. This is the slums. Here's another table for Alzheimer's with the warning signs for Alzheimer's if you're identifying that for someone. The Dimension and Delirium Table 6-1, and this compares Alzheimer's to dementia to delirium. Now, delirium is related to a situation. It's an acute onset of a medical problem. And we assume once the medical problem is fixed, then those symptoms will go away. There are two different types of confusion assessment methods that you might use in the hospital setting. There is one for ICU patients and there's one for non-ICU patients. But the goal is to assess for delirium. So how we are identifying the changes, we look at the acute onset. Is there any evidence that there's been an acute change in the mental status from the patient's baseline? And this can be a difficult thing to do if the patient has a baseline that includes dementia. But we're looking at the changes from baseline. Did any of the abnormal behavior fluctuate during the day? What is the pattern that we're seeing with the patient? We're looking to see if the patient has any difficulty focused. And again, these are changes that are occurring because delirium is an acute situation that is instigated by an event. So we're looking to see if the patient is having difficulty keeping track or something is happening. Disorganized thinking is the patient has incoherent thought, switching from subject to subject. And again, this is a new onset. And then finally, altered levels of consciousness. Is the patient has a baseline of being alert and now they're lethargic or drowsy or unarousable. These are changes from the baseline that we are looking at. But we know that there are some things, some episodes of delirium that can be managed by changing medications or identifying if the patient is having an infection or something like that. Things like UTIs, especially for older adults, and hypoxic changes. Some of the very early signs can be seen with changes in mental status. So we utilize these things to assess for delirium frequently. So there again is one that's a confusion assessment model for ICU and one that's non-ICU. And this is something you'll see in the hospital setting. When we think about assessing older adults, we're going to ask the questions and use possibly some screening tools. So we are looking for the older adults to see if there is something that are age-related changes that we might expect, or is there something pathological that's happening. So a lot of times when you are talking to patients about their changes or anything in their behavior that's been changing, is this something that's happened in a short period of time or over a long period of time? I think is important to know. So we're looking to see if there's any changes in thinking clearly, concentration, memory, or any changes in depression. Now, I would say, as many people might experience as they get older, more changes in their life. Maybe the death of a spouse or friend or family. These all can always be considerations when talking about issues with depression. So we want to identify any early warning signs, and we looked at the scale for dementia and Alzheimer's. So looking for any of those changes. But you're always going to assess somebody's vision and hearing. If you are trying to ask somebody questions, but they can't hear you, that's not about their mental status. That's about their hearing, right? So you would want to make sure. So just because somebody is having issues with mental status or history of depression, that does not mean that their intellectual capacity has changed. Just because somebody's older, that doesn't mean that's the case either. So we never assume that. Depression is not necessarily more common in older age than it is in anyone else. So that's something to note as well. So, but by 85, nearly 50% will exhibit some Alzheimer's dementia type disease. Those are the statistics. So in summary, you're going to know some of the risk factors and be able to describe an accurate assessment of these risks for mental health and risk for substance abuse. Utilizing your Glasgow Coma Scale is something you're going to do for all your patients all the time. And assessing for warning symptoms for Alzheimer's, dementia, and delirium. Being able to differentiate those, they're definitely important. Dementia is a long-term progressive issue where delirium is episodical. So want to be able to understand that from chapter 6. And then again, reviewing the confusion assessment instrument or the confusion assessment method is going to be important since you're going to be doing that in your practice. So I hope you enjoyed this presentation, and I want to leave you with something that I hope that maybe your knowledge with for yourself and for your patients maybe can save lives. I hope that going forward we normalize the discussion about mental status and anxiety, depression, and then if you know anyone that's in crisis, even if they may not be maybe just need to talk to someone and get some resources, I wanted to provide this prevention lifeline for somebody. And so that way, maybe there's an instance where you can share this and then we can save lives together. Thank you.